In the cervical spine, there have been clinical prediction rules for traction-responsive patients produced over the last several years. The most important is actually manually distracting the skull to see the effect. The two simplest ways to manually distract the skull is to have the seated patient behind the patient, the occipital area is grabbed by the doctor's hands, and the skull is elevated. This slight elevation allows you to turn the patient's head into the side of pain, seeing if it improves that, or have the patient raise an arm that was uncomfortable and finding if the pain is relieved. If so, there's a compression problem. Secondly, we can have the patient assume the supine position. We utilize the slip-stop blocks conveniently placed up at the trapezius area, which keeps the patient from slipping, and any one or various forms of manual distraction of the occiput. We can also rotate the head, or we can put it into hyperflexion. The patient's reduction of symptoms is a compression problem. In the lumbar spine, when a compression problem is manifest, a very simple thing to do is to judge painful range of motion, or if the patient is in discomfort simply standing, put your hands underneath the lower rib and apply just a little bit of upward stress. If this relieves the patient's pain, it's compressive. You can also have the patient bend into the side or the position that was once painful and see if it reduces the symptom. If it does, it's a compression problem. The next simplest method, have the patient assume a supine position, grab hold of the ankles, and comfortably add a distractive force. You can also create a distractive force by putting your hands underneath the bent knees and creating a pelvic tilt with a slight lift. Both will reveal a compression disc problem.